All right. Good afternoon, everybody. Thank you again for dialing into our Ask the Doc conversations with an oncologist. All lines will be muted for the remainder of the presentation, and we will have a question and answer portion of the presentation at the end, where we encourage you to type your questions in for our presenter. October is Breast Cancer Awareness Month. Breast cancer is the most common cancer among women in the US, with about 1 in 8 expected to be diagnosed in their lifetime. The good news, when found early through screenings like mammograms, treatment is often more effective and survival rates improve. Health experts recommend women begin discussing screening with their healthcare provider starting in their 40s or earlier if they have risk factors. This October, make time to learn your risk and stay up to date on screenings because early detection saves lives. To help us understand more, we have Dr. Cruz with us today. Dr. Cruz was raised in Chicago, attending Lane Tech High School. She received her medical and surgical training at the University of Illinois at Chicago before pursuing a breast surgical oncology fellowship at Advocate Christ Hospital. Dr. Cruz currently practices at Advocate Illinois Masonic Medical Center, where she is the medical director of breast surgery. Her areas of interest are advocacy, education, and raising awareness regarding the importance of breast cancer screenings. Dr. Cruz feels fortunate to be able to serve her community. Thank you so much for being with us here today, Doc, and I'll turn it over to you.
Good afternoon, everybody. We're just going to go over some basics about breast cancer and the importance of actually undergoing screening. If we can advance a slide. Great. So why is it important? Some of what we've already mentioned is that it is one of the leading causes of cancer death amongst women in the US. 1 in every 8 women, which is about 12 to 13% of the population, will develop breast cancer. It's not exclusive to women. 1% of cases are in men. So it is only second to skin cancer in terms of incidence for women. We can advance. I always like to start off by going over the anatomy of the breast because it can help with our discussion as we move forward. But the breast is a gland and it produces milk. Generally, it's divided into about 15 to 20 sections. It contains these lobes that produce milk, and of course, the milk flows through the milk ducts onto the nipple. In between the lobules and the milk ducts, there are fat, connective tissue, but also there is lymphatic tissue, vessels, arteries, and veins. Breast cancer specifically likes to spread to the lymphatic system. And generally, the reason that I allude to the anatomy is when I'm doing a clinical exam or clinical evaluation on a patient, those are areas of focus. So not only do I focus on the composition of the breast tissue, if I can feel any masses, any nipple changes, or the pigmented portion around the nipple, which is the areola, but the lymphatic basin. So 75% of the breast drains into the lymph nodes underneath the arm. The lymphatic system generally protects us from infections, but it is almost the highway or avenue that breast cancer can utilize to go to different parts of the body. Lymph nodes can be located anywhere in the body, and areas where we have concern for breast cancer are under the arm, like I mentioned, above the collarbone, and as well as the sternum. We can advance. So this is the prototypical depiction when we see the breast composition in a text. And I have another slide, but essentially it looks like these well-formed lobules and lobes that go into ducts and onto the nipple. If we can advance a slide, this interlay is actually much more complex. The lobules and milk ducts are interdispersed in the entire breast. And Cooper in the early 1900s actually took women that were deceased and were either lactating or postpartum and injected wax into the nipple to be able to lay out what the true anatomy of the breast looks like. And it is much more interwoven, almost like a spider web. So milk ducts and lobules are all throughout the breast. We can move forward. So like we said, breast cancer can spread to the lymphatic system. Typically, breast cancer starts in the milk duct. About 69 to 70% of breast cancer, the majority that we see, is ductal in origin. The second most common derives from the milk lobule, and there are other rare forms of breast cancer emerging from different portions of the breast. And for all races, the incidence of breast cancer increases with age. We can move forward. So, what are the main risk factors? I already mentioned aging, being a woman, early menarche, late menopause, the age of first birth being later, nulliparity. All of these do factor in, and I think a lot of patients harp on these, but there are other really modifiable factors, including alcohol and obesity, that, and as well as smoking, that I think patients can certainly, change their habits to lower their risk not only of breast cancer, but other maladies. Other risk factors that are important for any patient, regardless of their age. So most patients, we want to know this information at age 25 to see if they have an elevated risk based on family history or personal history of malignancies, such as patients that have ovarian cancer. We want to screen them for any genetic mutations or alterations, as ovarian cancer, as well as other malignancies, other types of cancers, can be associated with an elevated risk of breast cancer. Patients, if they undergo imaging and have an abnormality, can also be diagnosed with an atypical hyperplasia, often called atypical lobular hyperplasia, atypical ductal hyperplasia, or even something referred to as lobular carcinoma in situ. These are patients that also have an increased risk of developing breast cancer in either side and must be monitored closely. Other patients have had a history of cancer when they were young as children and underwent radiation therapy to the chest. These are other patients that are an elevated risk of breast cancer and should be monitored throughout the course of their lifetime. If someone has undergone hormone replacement therapy, conversation can be quite nuanced in terms of dosage and how long they were on the hormone replacement therapy, as this is providing the body with estrogen that the body does not naturally produce, typically referred to as exogenous estrogen, which can increase the risk of breast cancer. We can advance. So prevention, I alluded to this in the previous slide. How are we able to reduce our risk of developing breast cancer? Well, not smoking, activity, so diet and exercise are critical. There are patients that are candidates for medications such as tamoxifen or anastrozole, which lower the estrogen in the body to lower the risk of breast cancer. And that conversation is also very individualized. So I see a lot of patients in my practice that have undergone a biopsy or have a family history, and we go over all of these details, including, what is their own personal medical history? Are they an appropriate candidate for those medications? Other patients can actually have a genetic mutation, so an alteration or a change in their DNA that significantly increases their risk of developing breast cancer in a lifetime. And oftentimes, these are patients that have a long line family history of breast cancer or other malignancies. If they do carry a mutation, they may even be a candidate for what's referred to as a prophylactic mastectomy or removal of their breast tissue to decrease the risk of developing breast cancer. We can advance. Symptoms. So typically there are no symptoms. Most women, fortunately, now we are catching very early stage because they're screening breast imaging. And so preferable not to see any symptoms, as that usually corresponds with an earlier stage breast cancer. And so typically women will undergo a mammogram. And if they have dense breast tissue, they may be recommended a ultrasound, as tissue density is an important component when we're evaluating the breast tissue. For women that have dense breast, their tissue mammographically can obscure small masses, and so they may be candidates for additional imaging. Now, other women can present with an alteration or a change in their breast, such as a mass or a lump. a nipple discharge. So discharge that's coming out of one side, it may be clear, sometimes it may be bloody. Any form of nipple discharge would warrant a further evaluation by a breast surgeon like myself. Other women have changes in the shape of the breast where one breast appears to be smaller than the other. Anytime that you see that change, you definitely want to tell your primary care provider so that you may be referred to the appropriate clinician. Skin changes such as redness, swelling, flaking of the skin, changes around the nipple retraction, and even discomfort. Breast pain is rarely associated with breast cancer, but if someone is developing pain focally in the breast, we definitely need to do the appropriate diagnostic workup to ensure that there is no abnormality within the breast tissue that could be causing that discomfort. We can advance. So detection, and we're all about early detection. For most women in my practice, and what we're really trying to educate patients on is if they're over 20 to 25 years of age, we want to get a better sense of what their risk is. Now, about, I would say 80% of the breast cancer that I see is sporadic. So there is no family history of breast cancer. And a lot of the times when I have patients come in, maybe coming in because they're having breast pain or a mass that is benign, we go through that and they say, well, it doesn't run in my family, so I don't really have to worry about it. But no, the reason that we want to promote screening breast imaging is we want to detect cancer as early as possible. So most breast cancer, again, that I see day to day, the patient has had no family history of breast cancer. About 10% of the population can harbor a genetic alteration, a genetic aberration that raises their risk, and 10% of the population that I see that has breast cancer, it runs in their family. So for all women, generally we recommend after age 40 to undergo a screening mammogram. Now, depending on patient factors and family history, sometimes we do recommend undergoing imaging earlier than that. So mammogram is critical. We have robust evidence that it saves lives because we're able to catch this as early as possible. The clinical breast exam we're presenting to a specialist is also important, as we may be able to see something abnormal, get the appropriate diagnostics. I've had patients present with a mass or an abnormality that they're feeling. Imaging doesn't show anything, and then when they come to my office, I feel something abnormal. We do a biopsy, we do the appropriate workup, and we find an unfortunate malignancy, but a very treatable malignancy. MRI is a different form of imaging modality that is offered for patients that are also at elevated risk for breast cancer. This is a very specialized study. Usually it is offered to patients that have genetic mutations or are elevated risk based on family history and multiple patient factors. We can advance. So breast awareness, we can advance one more slide. Great. What we want to, really promote for everyone is to know your bodies. You know your body's the best. So not necessarily doing your own clinical exam, that's for the healthcare professional. But if you do notice a change in your breast composition or a mass, a skin change, or discharge emanating from the nipple. And I want you to remember that you don't just want to look at the breast tissue, but the area under the arm, as breast tissue extends to that space, and also the lymph nodes that we discussed. So if there is a change that you notice, we want to know about it. If you have a menstrual cycle and you're a woman, it's best to check your breasts about 8 days after the first day of the menstrual cycle. If you're postmenopausal or do not have a menstrual cycle, I usually advise everyone to, be aware of their breast the first of the month, and that way you don't forget. And no one is really symmetrical when it comes to their breast tissue, but if you do know what your baseline is, that way you can keep track if there is an acute change. Even if Once you do notice a change, you have to come in for evaluation. Clinical exam by a healthcare professional is, again, very important. A lot of the times we don't want to just say, oh, I don't feel anything, nothing's going on. We don't want to not go and get the appropriate clinical exam or imaging. That is critical. Next slide. So mammogram, again, very effective. This is very low radiation. It's actually even safe for women that are pregnant. So breast cancer that appears in either a pregnant woman or a woman that has given birth within a year can be an aggressive form of breast cancer. So any mass that you feel, if you're young and you feel a change, you should undergo the appropriate workup and appropriate imaging to rule out anything bad like malignancy. So we start with a mammogram. Here I put two representative images to just allude to that tissue density that I had talked about when we started our chat. If we look on the left side, this patient does not have very dense breast tissue. It's very easy to see that abnormality that's signaled with the arrow. You can see that that looks like a mass, as opposed to the image on the right side. This patient has very dense breast tissue. Her own breast parenchyma is very white, so it's very difficult to see any additional masses or any significant abnormalities beneath. Mammogram would still be important in both scenarios, as we can see an array of abnormalities such as asymmetries, calcifications that ultrasound or other imaging modalities like an MRI would not be able to detect. But if I see a patient with a mammogram similar to the one on the right, I would strongly advise an ultrasound for screening purposes. And we can advance the slide. So what are some barriers to just patients getting a mammogram? A lot of the times women say it is very uncomfortable. Of course, it can be costly and depending on if the patient is insured or not, but oftentimes women have a fear of finding out that they do have cancer. Again, I want to emphasize is we want to do mammography as early as possible for women after age 40, unless they have a strong family history, which that may shift when we would start. But even if it were to be the worst case scenario and we find a malignancy, as long as a woman's being consistent with her imaging or noticing changes, usually we've been really good at capturing breast cancer early on. And if we diagnose breast cancer early on and do appropriate treatment, survival rates are very, very high. And depending on the stage, it can be, over 90%. So also, I try to promote to my colleagues and clinicians that everyone should have, awareness of timing of mammography. If there is a change, then women should undergo appropriate imaging that's dependent on their age as well as their clinical presentation. Culture can also play a factor where women do not feel comfortable with undergoing forms of imaging or also connecting with the medical team or the hospital. Next slide. So additional diagnostics that we've talked about a bit, but ultrasound, biopsy, MRI, and additional complementary studies depending on the findings. If a patient undergoes a biopsy, we can advance. Ultrasound is a very important, like I talked about, for screening for women that have dense breast tissue. This may be recommended, or if a patient like this one presented with a palpable mass that felt abnormal on the exam, we would be getting diagnostic mammogram with an associated ultrasound. And under this ultrasound, this mass looks very suspicious for a breast cancer. But the overwhelming majority of masses that are visualized on imaging are benign. Only about 20% of the masses that I see are actual cancer or malignancy and would warrant additional treatment. So in this ultrasound, this mass has this really jagged, irregular appearance. It is almost casting a shadow of itself. And so all of those features on ultrasound tell me, well, this is a suspicious mass that would really warrant a biopsy to gather more information and determine is this a breast cancer? And if so, what type of breast cancer, so that we can do individualized treatment for this patient. Next slide. MRI. So I like this depiction of an MRI just to get a sense of what the test looks like. So MRI is done in this chamber. It's a longer exam. It's about 45 minutes. It utilizes a magnet to reproduce detailed images of the breast. And the reason that we obtain it for certain women, so women that are at an elevated risk for breast cancer for screening purposes, or sometimes I also order this form of imaging depending on the cancer diagnosis of a patient and multiple patient factors, but an IV is started, contrast is given, and it's almost like a blood flow study of the breast tissue. So the reason I say that is cancers like to make their own blood supply. And if there's an area that looks truly abnormal in the breast tissue, it can really facilitate the discussion that I'll have with patients regarding what type of surgical approach may be the best for them to undergo to treat their cancer. So MRI can get us a better sense of, is there any other additional abnormality that we're visualizing? Is that the only area of concern? Or is it bigger than what we're seeing mammographically or on ultrasound for certain types of breast cancers? Next slide. This is a depiction of an MRI of the breast. So when it's done at our institution, at any institution, it's a very detailed study and it's very colorful. And that can be very helpful to determine the treatment course for surgery, how well a patient potentially responded if they're a candidate for treatment prior to surgery. So for certain malignancies, we recommend something referred to as neoadjuvant or before surgery treatment like chemotherapy. And this is a good way for us to also monitor how a patient has done with that therapy and move forward if they're a candidate for surgery and proceed. Okay, we can advance. And so, we've been talking a lot about cancer, and I always also like to emphasize, well, what is cancer? It's the abnormal replication of any cell in the body. So we're specifically talking about the breast. So these are breast cancer cells that are growing without control rapidly, and in essence making their own blood supply so that they can obtain nutrients from the body to continue to grow and have, of course, the potential to spread. We can advance. So there's different stages of breast cancer. For breast cancer, we can even detect it as early because of how good mammography is at a stage 0. This is often referred to as ductal carcinoma in situ, when the cancer cells are still confined within the milk duct and don't have that potential to spread. Stage 1 to stage 4 are invasive cancers. So microscopically, when we are examining the tissue that we've obtained from a biopsy, we can see that the cancer cells are almost leaking out of whatever they're confined in. Like I said, the most common type of breast cancer is ductal of origin. And so we see that these cancer cells are leaving the milk duct with the potential to spread. Stage is often dependent on the size of the tumor and if there's any lymph node involvement. Stage 4 breast cancer refers to metastatic cancer or cancer of breast origin that has spread to another part of the body. So for patients that we are concerned that they have a later stage malignancy or potentially even a stage 4 breast cancer, we get additional studies of the body, which can be CTs of the chest, the abdomen, the pelvis, as well as a nuclear medicine bone scan to see if the cancer has spread. Other patients may be offered PET scan as well. We can advance. So I want to talk about some generalities again, just to emphasize the majority of tumors, about 80% that I see in the breast, are benign. So that's why doing the additional diagnostics are crucial. Not everything warrants a biopsy. Sometimes we are able to safely monitor masses or abnormalities in the breast that are seen on imaging throughout a course of follow-up diagnostics every 6 to 12 months. In the past, a lot of patients underwent multiple biopsies or surgeries that may or may not be necessary. So I want to emphasize that if you feel an abnormality, it's best to be checked because the majority of the time it's going to be something benign that may be even safe to monitor. 90% of early stage breast cancers, again, have very good survival rates. And typically, we can even do conservative management depending on the factors of the cancer, the factors of the individual. And just looking at 5-year survival rates, so patients undergoing treatment, completing their treatment, what is their survival rates 5 years after treatment? If we catch it very early stage, it can be upwards of 98%. When it's regional, meaning a higher stage, 84. When it's very advanced, like we were talking stage 3, stage 4, it can be very, that plummets to 23%. So again, the importance of undergoing screening as early as possible, or if you know a change, getting checked and going to your primary care provider and being referred to the appropriate clinician. We can advance. So treatment now is very individualized to the patient. And usually when patients see me in our clinic, they meet with the entire team. So it is a team approach. It's not only myself as a surgeon, but our radiation oncologist, our medical oncologist, social workers, our geneticists, our wonderful nurses. But treatment course can vary dependent, like we said, on the patient. With surgery, radiation may be offered to lower the risk of the cancer coming back. Sometimes chemotherapy, if it is going to be impacting survival, because we want our patients to have the best outcomes possible, may be also recommended. Hormonal therapy as well. So when we do a biopsy and we try to obtain more information about a breast cancer, we look at 3 features or characteristics, biologic features of the tumor itself, including estrogen, progesterone receptor, and a protein referred to as HER2. That information allows us to give targeted therapies to patients. And so that's why I mentioned the hormonal therapy and biologic agents, again, all individualized depending on what type of characteristic features the cancer has. We can advance. Just going over surgery. For patients that have small tumors or a small area of concern, they may be candidates for breast conserving surgery. This can be called lumpectomy or partial mastectomy, or a wide excision of the area of cancer. And the breast tissue is removed. It is sent off for analysis. The important part of the analysis is how big is the tumor truly, and are there any cancer cells around the margin? Do we need to return to the operating room to excise additional tissue for best outcomes for our patients? Now, for invasive breast cancers, some women may have to undergo a lymph node procedure or excision of lymph nodes under the arm. In the past, we used to do very extensive axillary dissections, often referred to as complete axillary dissections. And when we removed that degree of lymph nodes, patients were at a very elevated risk for developing something referred to as lymphedema, which is arm swelling, very uncomfortable for patients. So in the 90s, there was the advent of a new procedure that can be done at the time of the operating room for patients that we needed to sample the lymph nodes. And we were, able to avoid a very extensive dissection and obtain a few lymph nodes, gather more information so that we can counsel patients appropriately about their next steps in management. Next slide. Other patients, if they have breast cancer or if they have a very elevated risk of developing breast cancer because of a genetic mutation abnormality, may warrant mastectomy or removal of the entire breast. Removal of the entire breast does not eliminate the risk of developing breast cancer in the future. So this is done for selective patients. Also, it's a very nuanced discussion that I have with anybody that I meet. But some patients must undergo mastectomy if they have a large area of concern relative to the size of their breast tissue. And if they are going to undergo removal of their breast tissue, we want to offer reconstructive options, and there are an array. The picture that I'm demonstrating here is a patient that underwent a nipple sparing mastectomy where there's preservation of the nipple and an implant was later placed, and she had a very good cosmetic outcome. But there are different types of reconstructive options, not just implant-based reconstructions. Other patients are candidates for something that's referred to as an autologous reconstruction, where tissue from another part of the body is essentially mobilized onto that area to create a mound. Other women do not want to undergo a reconstruction, or it may not be safe from a medical standpoint, and patients do elect to go flat and have a horizontal incision where the breast once was. Those patients are prescribed bras that have an explantable prosthetic to create that mound. We can move forward. And I wanted to put some pictures of the different types of options that patients elect. This is an implant-based reconstruction similar to the one in the previous image. And then this is someone that has elected to not undergo reconstruction and go flat. We can move forward. So again, some points to remember, and then we'll leave some room also for questions. Breast cancer is not a death sentence. 90 to 95% of early stage patients have excellent survival rates, and over 80% of all breast cancers are diagnosed in women that have no family history. So strongly encourage everyone to, if you can, know your family history, and if you can't, just go and get screened. The majority of tumors that we do see in the breast are benign, and if you see a change in your breast, definitely meet with your clinician, with your physician, to, undergo appropriate imaging and seek out a breast specialist like myself. Early detection is critical, and it's important for us to discuss the topic. I think oftentimes, either in families or in friends, we think that it's uncommon. But like I said, this is a very common type of breast cancer, so we definitely want to be dialoguing more about it. And I think I have one more slide at the end. And so for Advocate Illinois Masonic, we have a comprehensive NAPBC, nationally accredited breast center. We provide breast health navigation. So any patient that is diagnosed is contacted by our navigator that helps with coordination of care so that it is as seamless as possible. We have a state-of-the-art facility, and we also work, like I mentioned, in a multidisciplinary team. So patients that are diagnosed typically meet with the entire panel. We also present each case in our tumor board that's comprised of all of the clinicians patients meet, as well as our imaging specialist and our pathologist. And treatment is always individualized and, really tailored to what the patient's needs are. We offer an array of support and coping resources for all of our patients that are diagnosed. And for patients that have a family history, we also have genetic counselors, which is very, very informative. And that way we can better be able to characterize someone's risk and what is the spectrum of that. I think one more slide. Okay, we talked about the multidisciplinary team already. And I talked about our genetic counselor, and we provide a lot of education. Let's say we have a patient that is found to be elevated risk. Let's say that they have a mutation. They've been diagnosed with breast cancer. They met with our genetic counselor and they carry a mutation. We also counsel their families regarding testing or what imaging and follow-up they would need. We also have a survivorship program. So that is for all of our patients that have been diagnosed with breast cancer, and very important to continue surveillance thereafter. And we work again in concert with one another. Next slide. Comprehensive treatment, it's not only the medical team that I discussed of the surgeon, the oncologist, the radiation specialist, and the plastic surgeon. We mentioned some of the reconstructive options previously, but we have physical therapists to reduce the risk of number one, lymphedema, something that can occur for certain patients when we excise an array of lymph nodes, but also the importance of exercise oncology. So we promote any patient that has had a diagnosis of breast cancer. We want to optimize their survival. We want to optimize their outcomes. We want to put them on a regimen of exercise so that they do well throughout the trajectory of their treatment and thereafter throughout their survivorship. We also have open and available clinical trials that we review with patients. And that, again, very individualized depending on the characteristic features of what we find. Next slide. I also see benign breast. Like I've mentioned, it's not only cancer, it's not only patients that are at elevated risk, but I often see women that are presenting that are lactating and develop a breast infection, often referred to as mastitis or breast abscesses, or women that are not lactating and have similar issues. Breast cysts, which are fluid-filled sacs, which exist within the breast parenchyma that are benign, sometimes warrant treatment. Nipple discharge, any form of mass, skin change, or breast pain. Next slide. And that's it. I'm going to leave some room for questions for everyone.
Yes, everyone, please feel free to type your questions in the chat. Thank you, Dr. Cruz, for this very informative session. I know I learned a lot from it. We'll give it a couple minutes just to put your questions in there. But if not, we will. Let's see. Do you have any information on diabetes and breast cancer? Is one of our questions.
Certainly, any patient that has diabetes, you always want to optimize your glycemic control. If you have undergone treatment or undergoing treatment, we want to make sure that that is as best as possible. So anytime I'm counseling a patient, if they're going to have surgery, well, patients that have diabetes have a higher risk of wound complications, such as infection or something referred to as wound dehiscence, where the area opens up. Diabetes is usually also found in concert with other medical comorbidities or medical issues such as obesity, hypertension, all of these things. So obesity, like we referred to before, is a modifiable risk factor. Where you want to be working out, you want to be dieting, you want to be changing things so that your BMI is optimized to lower the risk. Generally, for all women that I meet that are at elevated risk, we have a discussion about those factors, about smoking cessation if they're smoking, or not taking it on if they consume alcohol, generally 3 or fewer beverages a week, but also vitamin D supplementation and getting out in the sun and remaining active. I hope that answered the question. Any others?
Awesome. She said that yes, that did answer a question. Any other questions? Please feel free to type them in the chat. We have a couple minutes here. So one of the questions I have, Dr. Cruz, men can get breast cancer too. I know for a long time everyone just associated it with women. Um, what are some of the things that I'm a young man, for example. Is that something, what am I looking for, to be on the lookout for? I guess that's the question I should
Yeah.
ask.
Quite similar things to female counterparts. So any change such as a mass or discharge or the nipple areolar complex flaking or redness, something in the skin, you want to get checked out. Other patients that I've seen have a very strong family history of potentially breast or ovarian cancer. And then these men are found to have a genetic mutation. They meet with a genetic counselor. They either undergo a saliva swab or a blood draw, and they have a high risk. Sometimes men would feel uncomfortable with undergoing the screening imaging, as it is a mammogram and an ultrasound, and everything in breast is very, very pink, is what I would say. But I have had a good amount of men that have been referred to see me, have undergone the routine imaging, and they have been diagnosed with breast cancer, but fortunately it was very small because they did what they were supposed to do, which is continue to do the screening that they were offered. So that would include going to a professional like myself and doing a clinical exam as well, at least once a year. And for some patients, they're offered not only the mammogram that we discussed, ultrasound, but sometimes even MRI. So I think that it's very, very helpful to know more information. And if there is a family history of cancer, meeting with a genetic counselor. Other patients are adopted or do not know their family history of cancer because no one talks about it. Well, those patients are also appropriate to meet with a genetic counselor and have that discussion and see if they're a candidate for an extended panel to make sure that there's nothing else that could be influence the discussion regarding, monitoring long term. And
Excellent. And
generally,
no,
so
please continue.
sorry, but generally when we see breast cancer in men, we're concerned that they do have a genetic predisposition, especially because it's so rare. So all men that do have a diagnosis of breast cancer are immediately offered genetic testing.
So would you say that the family history is one of the big red flags for men? Just in general, obviously, I know it's very personalized, but family history should be kind of the indicator of, okay, I should get some type of genetic testing.
Yes, even, pancreatic cancer or even for some men, prostate cancer can be associated with breast and certain mutations. So it's not only, breast and ovarian, it's an array of other maladies.
Understood. Well, it looks like we don't have any other questions in the chat. I just want to remind everybody that this is a self-reported activity for Motivate Me. Remember, you have until October 31st to do that. You can report today's date in the MyCigna app before October 31st. I'm going to repeat that. If there are any other questions, please don't hesitate to reach out to us at the wellness team, wellness@transitchicago.com. I want to thank everybody for attending today's lecture. I want to thank Dr. Cruz for providing this amazing information. I know something that when I was growing up, breast cancer was always something that I just assumed only women could get. But, as I got older, I understood that, everybody can get breast cancer. So helping to understand those risks is very beneficial for me as well. So I want to thank you, Dr. Cruz. This will now conclude our presentation. Thank you all for joining us and I hope you have a wonderful rest of your day.
Likewise. Thank you, everyone.
Take care.